you have your writing hands ready because we're going to talk about the deep front line. And it is easily, just as you can see from the picture, the most involved line that we're going to talk about. It's about as opposite of the simplicity of the functional lines as we can get. Functional lines, each one, there's three of them, but the functional lines each had three muscular tissues, just a little bit of bony attachments, not a lot of additional fascial tissues. Deep front line, basically, everything that we haven't talked about in the superficial back line, superficial front line, lateral lines, spiral lines, three functional lines, all those excluded tissues that aren't the upper extremity, they're just all lumped into this line. So there is, this line is very involved. And you can just, if you start at the top, and this one doesn't even have all of them because I ran out of space. When was the last time you guys talked about or considered the omohyoid? Or the digastric? Or better yet, the pterygoids, which start with a P. Even know where the pterygoids are? If you want to know where the pterygoids are, you take your finger, put them inside your mouth, just outside your upper molars, and that's right where the pterygoids are. They sit right behind the zygomatic arch. So we're talking about muscles that we might not have even considered for a very, very long time. And they're part of this line. Now, even though it does seem like it's all pieced together, it's not. They didn't just take the pieces that were left over and throw them all in here to come up with this final line. When we look at all the tissues involved in this line, one of the things that we are going to notice is they're relatively all smaller muscles, obscure muscles that we might not have heard about before. And they're very deep. They're going to be hard or difficult to access. Now, as soon as I say that, I've got to take a step back. This line does involve the psoas, it does involve the iliacus, we've talked about those before. This line does involve several of the adductors. We've talked about the adductor longus. We've talked about the adductors before when we talked about the front functional line, spiral line. So we've kind of come across those before. So there is a little bit of crossover with the adductors into some of the other lines. And yes, the psoas is a relatively big, strong muscle, but everything else in this line, again, is a very deep muscle and not a big, strong muscle. So as soon as we look at this and as soon as we start to see these, we had to describe this line as a line that generates power, a line that generates control. It's going to be predominantly towards the side of generating control. It's not one of those, it's a big, strong line. It's all about when it turns on and when it turns off and how it can exert that control. One thing that's unique with this line compared to the other lines that we've talked about that were all about control, this line hugs the axial skeleton. This is as midline, as close to it's as deep as you can get. So because of that, because of its close proximity to those deep structures, to the spine, to the vertebral bodies in the pelvis, when we start talking about what it does from a control standpoint and how it turns on and turns off, it exerts a lot of control over the spine, over the pelvis. One of the terms that drives me absolutely bonkers, and I refuse to use it except for when I reference it, is the term the core. We do core training. And first and foremost, if you can't define what it is, you can't train it. And the fact that if I ask you guys all to write out what the core is, I'm going to get 8 different answers. There will be some crossover, but we're going to get 8 distinctly different answers. So if we can't define what the core is, but we talk about the core, and we can't agree upon what the core is, we don't have any clue what core training is. And when you look at social media, when you look at what's being thrown out there as core training, basically core training is just a way to train your abs. We've taken abdominal training from the 80s, we've taken sit-ups, we've taken crunches, we've taken all of that stuff, we've put a nice little marketing spin on it, and we're going to call it core training, and we're going to hype up how important core training is. Now, unfortunately, there is a little bit of truth to all of that. Addressing and controlling the core is important, but we have to understand what the core is. And if we don't understand what the core is, we can't really say we're doing core training. This is as close to the core as we can get. When we talk about the core, if you ever hear me say the core, I'm using that term synonymous with the deep front line. Now, I will say, odds are you're never going to hear me say the word the core unless I'm talking about core training from a marketing standpoint. I'll refer to it as a deep front line. This is as close to the core and an actual definition of what the core is as we can get. Now, when we look at that, the first thing that jumps out, there's no abdominal muscles. So first and foremost, if we look at this, what the function of this line is, the components of this line, and compare that to the traditional thought and the traditional mindset of what we do for core training, we immediately have something that doesn't line up. And again, that just goes back to what we have been conditioned to understand as core training is just fancy abdominal work from the 80s. Go watch Rocky. Watch Rocky 4 when he's training in Russia to fight Ivan Drago. That's the greatest expression of core training that you're ever going to get. And all it was a bunch of fancy sit-ups. That's the best expression that we can get. Everything else is just trying to live up to what they portrayed in that movie. So that being said, going forward, we have to have a little bit of a different understanding of what the core is and how we actually need to address that from a rehab standpoint. Because we can get a lot of value out of addressing the deep front line from a rehab standpoint. Rarely is the deep front line is like that friend. The deep front line is like that hype man. He's that person in the group that gets everybody all hyped up, but when it comes time to actually do the thing, he's not really able to do the thing, so he just brings the energy. That's the deep front line. The deep front line is the hype man. Can't really do anything. Look, how strong do you think the omohyoid is? We've been talking about the size of the anterior tibialis compared to the gastroc. The omohyoid is the little piece that fits inside here that plugs into my USB. That's the size of the omohyoid. It's not going to do anything. It can't. So when we look at the function, the muscles of this line, they're not big, strong muscles. They can't really do a lot. Because of that, if they aren't doing their job, we're not going to see these giant changes. The glute med doesn't do its job. We see things from that. The hip abductors don't do their job. We see things from that. We test the Trendelenburg. We see a lot of lateral hip sway. We see all of that. If the rectus femoris can't do its job, we can't fully extend the hip or the knee. We run into that from a rehab standpoint all the time. When the muscles of this line can't do their job, they don't know what we are visibly able to see, there isn't much there. Because they don't do a lot from a movement standpoint. What they do is they control things. They hype things up. So because of that, the deep front line, if there's a problem in the deep front line, barring a hip flexor, a psoas, or a diaphragm problem, those are our two exceptions, psoas and diaphragm. Other than the psoas and diaphragm, if there's an issue anywhere else in the line, you're not going to see it. At the same time though, anytime we have a fascial line issue, pick whichever fascial line it is, you tell me that you go through and based off of the history and what you've assessed with the person, you're really leaning into it being a superficial backline issue, there's a deep front line tie-in. Because remember, the deep front line is the hype man. It's always there. It might not be the reason, it might not be the one doing the thing, but it's always there. It's never the problem, it's never the star, but it's always there. So if we have a deep front line issue, if we have a superficial backline issue, we have a deep front line issue. If we have a lateral line issue, you have a deep front line issue. If you have a spiral line issue, guess what? You don't have a deep front line issue because I'm kidding, you have a deep front line issue. There's always a contribution of the deep front line when there's something else going on. Now, that leads us to the discussion of, is it a chicken or an egg type discussion? Does the deep front line issue, the issues within the deep front line not doing its job, cause the lateral line to change what it's doing? Maybe. Or does a lateral line and its inability to do its job cause the deep front line to change what it's doing? Maybe. We don't know. So that's why we can't necessarily, we can get hung up in the cause and effect, which one causes, where does it all come from? But at the end of the day, just like any chicken and egg discussion, we need to make our omelet. We need to quit discussing which one came first. Let's just make the omelet and move on. You have a lateral line issue, we have a deep front line issue. We need to address both at the same time. And this is, from a rehab standpoint, where the biggest mistake is made. We'll address the lateral line. We get it taken care of. We get it moving in a better direction. We forget about the hype man. And just because the hype man's quiet doesn't mean he's not going to start causing problems when we let that person go back and start doing the thing that they're doing. That's when the hype man starts doing his job. So we'll take care of the lateral line issue. We don't address the deep front line issue. Things get better. We let them start to return back to the activity that they were having issues with. There's still that little deep front line issue that's going on that we neglected to address. And guess what? As soon as they start doing the thing again, it's going to start hyping things up. We're going to see them start to backslide. So that's why we have to always consider the contribution of the deep front line. We always have to assume that there's a deep front line issue, and we have to address that with everything else that we're doing for whatever the primary line that we feel is involved is going on. So if we're addressing the superficial backline issue, I'm considering the contributions of the deep front line. Same thing for lateral line, spiral line, arm lines, everything else. Because if we don't, that's when we see the patient get better, but as we start to reintroduce them, we start to see them backslide because we didn't take all the things off the table. How can that be? Very simple. Breathing. Once again, we're back to talking about breathing. The diaphragm, let's just say this. Any activity where the person is breathing, the deep front line is involved. And if we don't address that, there's going to be an issue. Now, those instances where the individual's not breathing are very few and far between. Free diving, where they go down as far as they can on one breath hold, doesn't involve the deep front line because it's not actively doing anything while they're holding their breath. So we found the one exception. If you're working with a free diving athlete, we don't need to consider the deep front line. Everybody else, it's going to be a consideration. All right, so, do you want me to read all these? I mean, there's so many of them, the font got smaller to fit into the box. We have our posterior tibialis, the flexor hallucis and digitorum longus, popliteus, the three adductors, magnus brevis and longus, the pectineus, 9 muscles of the diaphragm, including the levator ani, obturator internus, the psoas, the iliacus, the QL, the diaphragm, the transverse thoracic, the scalenes, the longus colytic longus, capitis, omohyoid, digastric, masseter, temporalis, and last but not least, the pterygoids. I really think it's just pronounced the pterygoids, but I like saying the pterygoids, like the pterodactyl and everything else. There's a lot in this line. I mean, I didn't even take the time to name out 9 muscles of the pelvic floor, the pelvic diaphragm. There's a lot of muscles. And it spans from the bottom of the foot because posterior tib, flexor hallucis longus, digitorum longus wrap the bottom of the foot. So we know there's a contribution to the arch with this. They make their path up through the knee, through the pelvis, up along the spine, into the deep muscles of the neck. When was the last time you guys palpated the longus coli? Let me guess. Safe bet is you probably never have, and you probably never will. Because the longus coli, easiest way to access it is right here, just lateral to your trachea, medial to your the sternocleidomastoid, but all the way back at the vertebral body. So go in about 3 inches. If you want to try that, go for it. You'll find your longest coli, but I think you'll be distracted when you get there and you won't appreciate it. It sits on the very anterior part of the vertebral body. Same with the longest capitis. So they're there. We can't really do much about those. And that's kind of the key with this line. There's a lot that we can't necessarily get to. Now, you're thinking we can't get to levator ani, but like I told you guys that were in class yesterday with the needling, that was our first needling experience in one of the courses I went to. We can access some of these areas. Some of them we can't. So we have to and because it spans from the bottom of the foot all the way up to the top outside of our lateral aspect of our head, because it spans all of this and everything in between, that's one of the reasons why we need to consider it with the lateral line. That's one of the reasons why we need to consider it with the superficial back line. Anytime when we were talking about the superficial back line, we talked about the importance of the suboccipital muscles and their tie-in with vision. Anytime I'm dealing with somebody with suboccipital issues, one of the places I automatically go is down here to the posterior knee. Where is it? It's in here somewhere. Popliteus, where are you? There it is, all the way up the top. I come all the way down to the popliteus and address the popliteus. Just because, and then if we're addressing the popliteus, we have to consider the joint capsule of the knee, just because of the tie-in between the deep front line, where that's going, and what it is I'm trying to fix. Some kind of hip flexion, knee extension, some type of systemic flexion. We need to look at those and consider those. And that's an easy area for us to address. It has a direct tie-in to the knee. From a bony anatomy standpoint, we go from the jaw to the hyoid, the base of the skull, the manubrium, the sternum, and the xiphoid, the transverse processes of the cervical vertebrae, the lumbar vertebral bodies, as well as the transverse processes of the lumbar vertebrae, down to the femur, lesser trochanter of the femur, medial femoral condyle, the coccyx, the ischial ramus, all the way down to the posterior aspect, the superior posterior aspect of the tibia and the fibula, and then down to the bottom of the foot, plantar surface of the tarsals, plantar surface of the toes. We don't include the calcaneus, we don't include the talus. So again, when we look at it from a bony anatomy standpoint, we go all the way from the head down to the feet, and we're hitting everything in between. And we're hitting multiple places. Like we have the shaft of the femur, the lesser trochanter of the femur, and the medial femoral condyle. How involved do you think femoral movement is with the deep front line? It's extremely involved. We have 3 contact points there. Same thing at the pelvis. We have the coccyx, the ischial ramus. So again, we now have another connection into the pelvis that we haven't talked about yet. Sacrum's not included in here, though we can consider the sacrum, but it's not a formal part of the line. And when we talk about the hip rotators, we'll talk about that tie-in just a little bit. And then we also, for the first time, we get our sternum, the middle part of the chest. This is our first tie-in to this. So we have, and we're going to spend quite a bit of time talking about the mandible and the hyoid, because of what that does and how that starts to tie some things together that we oftentimes don't consider from a movement or from a rehab standpoint. So with the other tissues, the capsule of the knee, the joint capsule, the anterior longitudinal ligament of the spine runs basically from the front side of the sacrum all the way up the anterior side of all of the vertebral bodies up into the cervical spine, pericardium, mediastinum, parietal pleura, and then the anterior sacral fascia. So now we're actually getting into some actual non-musculoskeletal things. We're actually getting into the vital organs of viscera. So that also opens the door. Now we're talking about a fascial line that has a very acute and a very direct tie-in and significant influence from and on our autonomic nervous system, which shouldn't be a surprise, because what's the easiest way that we can access the tone of the autonomic nervous system? Breathing. Diaphragm. Now it's not just the diaphragm, we actually have that tie-in to the viscera. So this line is very responsive from the autonomic nervous system and provides a lot of influence into the autonomic nervous system. Which now means if we actually have a true core issue, a deep frontline issue, we also have an autonomic nervous system issue. Which now if we take that one step further, if you have a lateral line issue, we know there is a tie-in to the deep front line. We know there's probably some involvement of the autonomic nervous system. One thing that I don't think we appreciate, and I haven't done a good job of explaining this to you guys, tone of a muscle is input to the nervous system. So resting tone is an input to the nervous system. Now, to play devil's advocate, well, isn't that also an output? Yes, it is. It's one of those cycles. It's one of those, you make a bad decision that leads to a bad outcome, you make another bad, you start this negative cycle. It's very much like that. When you have increased tone, that's a sensory input. The nervous system processes that. We don't like change. This now becomes normal. The allostatic model of maintaining a normal condition. That low level of tone now becomes normal, so we have to maintain the tone. That tone becomes an input. Hey, we've got some tone here. We need to adjust this. Let's keep the tone. Let's keep normal. And we get this giant, nasty spiral, and we can't understand why our biceps has always got tone in it. Or why, even better, that person that just literally has steel cables for erectors because they're always on. That's an adaptation over time. That becomes a self-fulfilling prophecy to the nervous system. My erector spinae carry a high level tone. That now must be normal from the nervous system standpoint. Let's bring more tone onto the table because muscles doing things, they can only do one thing. They're either on or they're off. And so if they're on, let's just keep them on even more. That becomes a painful situation because of the metabolic waste products of that muscle always being on. When that muscle's always on, we include blood flow. Good stuff can't come in, bad stuff can't go out. We have we've created a somewhat of an ischemic environment because of the pressure within the muscle. Ischemia is painful, which is input. Oh crap, this hurts, this is bad. We've got to do something about it. Well, what can the muscle do? The muscle can turn on even more, which creates more ischemia, and we just continue this giant process. And now, we're talking about tissues that involve the heart and the lungs. So, again, we're right back to breathing, and when breathing is affected, it has a ripple into a lot of other areas that we don't fully appreciate. Deep front line, it gets kind of confusing. It's kind of like a choose your own adventure book when you get up to the psoas. Yeah, and I said psoas because I like doing that sometimes. When you get up to the psoas, it's kind of like a choose your own adventure book. You can go through that anterior longitudinal ligament and keep the forces in direct contact with the anterior portion of the vertebrae. You can come up through the diaphragm, up through the parietal, the pericardia, mediastinum, and parietal pleura, into the two coli, the coli and the capitis that will never palpate, up into the anterior neck, or we can come up into the diaphragm, take a path through the sternum, take a path through our infrahyoid muscles, into our suprahyoid muscles, into the anterior jaw, into the mandible. So we kind of have a little bit of a choose your own adventure. Now, if we look at that though, that provides a lot of control to our trunk. That provides a lot of control to the neck, to very sensitive tissues. Kind of run into the same thing at the pelvic floor. I don't have a diagram of that, but we kind of see that spread out at the pelvic floor as well. So in those areas where we need a lot of control, the deep front line doesn't just have one line of pull, doesn't just have two lines of action, it provides three. So we can get very precise with how we choose to control this, which is a double-edged sword, because if we have a problem here, it's going to have a magnified effect on the neck, on the trunk, on the pelvic floor. So it's got good, it's got bad that goes along with it. This is our core. If you try to think of this like the superficial back line as a very linear line, it's just going to drive you crazy. How they describe it in the book, this is less of a line, more of a 3D model of what's going on. So think of this one more in 3 dimensions, less of that linear line, like it's easy to think of with the front line, the superficial front line, superficial back line, lateral lines, or even the functional lines. There is a very intimate relationship with the internal viscera in this line, which again takes us back to conversations about the autonomic nervous system. There's a very intimate relationship with the hip, the actual hip joint. And then again, autonomic nervous system is both heavily influenced by and exerts a lot of influence on the deep front line. From a postural standpoint, because of the flexor hallucis longus, flexor digitorum longus, and posterior tibialis, how they wrap around the bottom of the foot on the medial side, we have significant contribution to the medial arch, which lets us also know that if we have influence and control over the arch, it's also going to influence and control what the knee is doing in regards to a varus valgus type situation. So it's very influential in controlling that varus valgus of the knee. If we want to take the thought, well, varus valgus in the knee doesn't come from the foot, it comes from the rotation of the femur. We have 3 attachment points through the femur from the deep front line. So even from that aspect, if we consider top down instead of bottom up, if we consider valgus coming from the hip and not from the foot, it still points us to deep front line. So regardless of what our thought process is, medial lateral control of the knee is significantly influenced by the deep front line. You have anterior lumbar support. That's like lumbar support, only a knockoff. So because of the psoas, because of the iliacus, because of the quadratus lumborum, because of the anterior longitudinal ligament, we get a lot of anterior support of the vertebral column, especially the lumbar spine. Intra-abdominal pressure, we have the pelvic diaphragm, we have the pelvic diaphragm on the bottom, the actual diaphragm on top. Those two working together are very influential in creating and maintaining appropriate intra-abdominal pressure. What wraps the outside, transverse abdominis, the obliques, rectus abdominis, those are coming from other lines, but when we talked about that before, we talked about that as one cylinder. Now we can kind of peel those layers away. The most influential part of that cylinder becomes the diaphragm on the top and the pelvic diaphragm on the bottom. What the other sides of that cylinder, the external obliques, transverse abdominis, rectus abdominis, all they're doing is helping to maintain that. They're there to assist the 2 diaphragms doing their jobs. So the 2 diaphragms are very important when it comes to intra-abdominal pressure. Literally, the diaphragm is the middle point of this line. If we're going to have any consideration of breathing, every discussion we've had about breathing, it's also a discussion about the deep front line. But you can't have a discussion about breathing and not consider the deep front line and vice versa. And then because of the 3 different tracks that it takes up through the anterior, up through the neck, it exerts significant control and support for the fragile structures of the neck. Common issues. Movement function, sorry. About the only actual movement that this line does by itself is adduction of the hip. The entire adductor group is part of this line. So if we ask this line to do something, the only actual movement from a range of motion standpoint that we can measure would be hip adduction. Beyond that, we can expand the abdomen when we activate the diaphragm, pull the lungs down. That's going to create a secondary expansion of the belly of the abdomen, not because we're engaging the abdominal muscles, which would actually create the opposite effect, restriction or constriction of the abdomen. The diaphragm actually creates abdominal expansion. Because of the tie-in at the jaw and the anterior neck, significant neck control and a tie-in, a very heavy influence in our tie-in to language and anything that we're using our jaw for. So eating, drinking, anything along those lines. When we look at this line in general, once again, we're back to type 1 fibers, endurance-based fibers. There's not a lot of power that comes from this line, and we don't want this line creating a lot of power. This is a line that needs to be able to continually turn on and turn off over an extended period of time. When it can't turn on, we have problems. When it can't turn off, we have bigger problems. So we need this line to be able to function at a low level, all waking hours, to help us control whatever position posturing that we're in. Common issues that we see with this, outside of breathing issues with the pelvic floor, and issues with the jaw, there's no actual problems with this line that are directly related to this line that we're going to visibly be able to see. If we have a breathing issue, we have a deep front line issue. Somebody has TMJ issues. We run into that occasionally from a rehab standpoint or with the athletes, with the patients that we're working with. Somebody has a TMJ issue, they have a deep front line issue. Somebody has a pelvic floor issue. It's not just a pelvic floor issue, it's a deep front line issue. Again, if we have an issue in this line, it's not like we're going to we're not going to be cued onto the fact that this line's involved because somebody's missing elbow flexion or because somebody's missing shoulder extension. So if somebody has an injury, somebody has something, and they're seeing a progressive loss in range of motion, it's not going to cue us into this line. Whereas if somebody can't fully extend their knee, I have to consider the superficial front line, superficial back line, that tie-in. Can they not extend their knee because they can't generate enough force in the superficial front line to mechanically pull the knee into extension? Or is it because that superficial back line is so tight that it won't let the superficial front line pull the knee into extension? We're not going to run into situations like that with the deep front line. We're not going to see somebody that has a hip rotation issue and automatically think this is a deep front line issue. But at the same time, we always have to consider there's a deep front line issue. There's always a consideration. All right, so said there wasn't any sacral involvement in this line, and there's not directly. One of the tissues that we mentioned was the anterior fascia of the sacrum. But one of the things, when you look at this, when we finish talking about the arm lines, and you go back and you look at this, one of the things that's going to jump out are the muscles that we've neglected to talk about. And when we do that, there's very few. Biceps are in the arm line. Triceps are in the arm line. Upper traps, arm lines. Rhomboids, arm line, spiral line. Rectus abdominis, superficial front line. Obliques, spiral line, functional lines. We can sit here, and the common muscles that we deal with from a rehab standpoint are included in all of the lines. There's very few muscles that are actually excluded from our lines. The ones that tend to jump out the most is, what about the deep rotators of the hip? They're not included in any line. They're not a part of the deep front line. And so when you talk about the deep rotators of the hip, we're talking about superior inferior gemelli, talking about the obturator internus, it's not on this picture, and then the quadratus femoris. They're not technically a part of this line. And the reason they're not a part of this line is just because of the orientation of their fibers. Which, if I were to raise any questions about anatomy trains, this would be where I'd raise the questions. Because we're not considering the deep rotators of the hip because of the direction in which they're going. But we do consider the pelvic floor. And the obturator internus is part of the pelvic floor. And it runs this direction. So how is the obturator internus in isolation a formal part of this line, but the gemelli, which sit right above it and right below its tendon, aren't. Why is the piriformis, which runs the exact opposite angulation of the obturator, why is the piriformis not part of this line? So those would be the questions I would ask. Now, it's not a formal part of this line. I think it's worth a consideration. If we have somebody with hip issues, yes, this isn't a formal part of the line, but I do think this warrants a little bit of investigation if we're dealing with somebody with hip or pelvic issues. Just because this is the logic to exclude this is very thin. And why would we even have this conversation? Because I think we need to consider the deep rotators of the hip a little bit more than we do from a clinical standpoint. Somebody has a shoulder issue, we're always considering the rotary cup, because the entire function of the rotary cup is to keep the humeral heads sucked into the glenoid fossa from a stability standpoint. We don't want the rotator cup to necessarily be strong. These aren't strong muscles. These are muscles that turn on and turn off. Well, if we just look at the muscles, we have broad, rather large, I won't say large, but we have a muscle area that comes in and attaches in very close proximity on the humeral head. Well, if we look at the head of the femur, the greater trochanter, it looks very similar. We have these tendinous attachments at one point that come from a fan-like approach from different areas, from the sacrum, from the ischial rami, from the actual inside of the pelvic floor, that then loop out and work and have an interaction on the greater trochanter of the femur to help control the femur. Now, you'll notice right away, these muscles are significantly smaller. Any idea why? It's just because I made that picture bigger. So that's the whole reason why those muscles are smaller. But then also, from an actual answer question, the shoulder is an inherently unstable joint. You have a very small labrum and a very large femoral head. The hip is the exact opposite. The head of the femur actually sits inside of the acetabulum. It's a very stable joint. A very stable joint, a very unstable joint. A lot of static stability from anatomy, very little static stability from anatomy. So we need dynamic support. The rotator cuff has to be larger, it has to be more robust than the rotator cuff of the hip. So you have larger muscle bellies. You have the muscles that fan out into a larger area that focus in to control that shoulder because it has to provide more stability. The deep rotators of the hip, they don't necessarily need to provide a lot of stability to the hip because it's statically a stable joint. But they are still very much involved in the rotation of the femur. And really where we see this becoming a problem is if these become shortened. How do you know if the external rotators are shortened? Just watch somebody walk. Because if the deep rotators of the hip are shortened, where do the feet go? Do they stay pointing straight ahead? Do they internally rotate? Or do they externally rotate? If our external rotators of the hip are tight, we're going to be standing with our feet out. So if you watch somebody walk, and they walk with their feet turned out, it's probably a good bet if you go and you look at the hip, we're going to see some tightness within those external rotators. That by itself is not a problem. And this is a great example of why I think this should be a part of the line. Lack of rotation of the hip by itself is not a problem. We're not going to see any issues with that. That's not going to cause us any problems. What we're going to see, what this person is going to present as, is Bass Pro Marathon was a couple weeks ago. Dogwood Canyon, like 100K race was last weekend. You have all these people that for 9 months out of the year are relatively sedentary. But starting in August, they start training for these large, long distance events. And they take off running. And they run, and when you watch them walk, You watch them walk with their feet turned out. Here's a little tip. Anytime you add speed or velocity to anything, it makes whatever problem's there, it magnifies it. So if I walk with my feet turned out, I'm going to run with my feet more turned out because speed and velocity don't tighten things up. Any of you guys, when you were younger, ever ride your bike going really fast down a hill and that front wheel starts to shake? If you're on a bike, that happens, you have a little bit of control. But what happens if you're on a skateboard and you start to get that speed shimmy? Then the speed shimmy turns into the death wobble, which turns into road rash. Because as soon as you start to see that, there's no coming back from it. And that person's going to end up on the ground because of speed. Why can you fix it on the bike? Because the bike has brakes. As soon as that happens, you slow down, the speed wobble goes away. Skateboard doesn't have brakes. The only way to slow down the skateboard is to create friction with the ground, which is what happens because you hit the ground. Scooter, same thing. That front wheel starts to wobble on the scooter, they're going to bite it unless they slow down real quick. So when we have tightness in the deep external rotators of the hip, and I stand like this all day, this isn't a problem. Will this create issues over time? Yeah, I'll have some deep achiness in my hip. I might develop sciatica and have to get an injection, but it's not a sciatic nerve issue. It is an external rotation issue. But when I start to run, I'm going to magnify this. I'm not going to complain of hip pain. I'm going to complain of foot pain. I'm going to complain of medial knee pain. I got shin splints and I don't know how I got them. Shin splints is a volume problem 100% of the time. Now, one of the considerations when you have shin splints, yes, it's a volume problem, but I want to know what your mechanics look like, because if every foot strike, your foot's like this, and we're passing that force up the tibia, it's a volume problem, but we hit that volume ceiling a lot earlier because of where the forces were directed. We can fix things by changing the direction of your foot. Your ankle is supposed to go into dorsiflexion, plantar flexion. It's not supposed to use inversion and eversion to propel us forward. But when you actually rotate, that's what happens. Your knee is a simple hinge joint, flexion and extension. It flexes and extends when the toe's pointed straight ahead. When the toe's not pointed straight ahead, now we don't have flexion and extension. We get this weird rotary component, which causes problems. It's going to cause a problem with your knees. People don't have bad knees. You had good knees, you've just used them wrong. So we have to, I think it is very much worth considering the hip rotators because of what we see from an injury standpoint, and the downstream effect that tightness here creates. Because if we have tightness in our hip external rotators, once again, that's the hype man, we're not going to have hip problems. And if we have hip problems, the only hip problem we're going to have is sciatica type sensations, numbness tingling down the back of the leg. What we run into is medial foot pain, shin splints, stress fractures of the tibia, medial knee pain, especially as our running and our training volume increase. We won't necessarily think it's a hip problem. How many times with a tibial stress fracture do we do all the right things? We remove them from the activity. We consider their diet. If they're a female, we oftentimes increase iron in their diet. We do all the right things. We do the strengthening, we do the stretching, we do the soft tissue work to address it. We literally do all the right things. And as soon as they go back to training, we see this come back. It comes back to the fact that we did all the right things here, but we didn't consider the deep front line. Because we have to then consider what's going on up at the hip. Because if we do all the right things here, we make them better. And as soon as they go back to activity, that foot strike comes just like this because of the tight rotators up in the hip. Now, the nice thing is we can address these. There's a lot of amazing stretches for these. Not necessarily the best strategy. It's part of the strategy. It shouldn't be the whole strategy. We have to be able to do some soft tissue work into this area. You can try to foam roll this area. Unfortunately, you have this giant glute that sits here. So you sit on the foam roll, it's going to be a little uncomfortable. if we were to look at actually how much force is getting into these muscles, it's going to be minimal. You can't grasp in it. You can't, there's not a lot of good options. This is an area that responds very well to dry needling. And it's a very easy area to access because we can access it through the greater trochanter. You find the greater trochanter, you go just on the back side of the greater trochanter. We can actually get needles into the piriformis, into the gemelli, into the tendon of the obturator, and into the quadratus femoris. All right here. And we can access it without having to go through the larger muscles. And this is an area that, believe it or not, actually is very insensitive, meaning you don't really feel a whole lot when it comes to needling. Seems to me like it would be a very sensitive area, but it's surprisingly not. So this is an area worth consideration, especially if we see any foot, knee. For the rest of the day, just watch people walk. If people walk with their toes turned out, deep hip rotators. If people stand with their feet turned out, deep hip rotators. We know it's an issue. Pelvic diaphragm. 9 muscles. Bless you. They attach from the sacrum out to the ischium, ischial tuberosity, to the ischial ramus, to the backside of the pubic symphysis. When we come to the other side, we see the obturator internus actually comes in, attaches to the femur. Again, I think this is an area that we throw out the term it's a pelvic floor issue and we just kind of write it off. It's a pelvic floor issue. It is what it is. Because of the tie-in with the deep front line, if you have a pelvic floor issue, it could be tied into the foot problems that person's having. If you have a pelvic floor issue, it can be tied into the TMJ issues that person's having. If you have a pelvic floor issue, it can be tied into the psoas, the hip extension issues that you're having. If you have a pelvic floor issue, it can be tied into your inability to fully extend the knee. The pelvic floor is tied to, because of the deep front line, it has a direct fascial tie-in to every tissue from the jaw down to the bottom of the foot. So when we have a pelvic floor issue, it's not just incontinence. When we have a pelvic floor issue, we have an inability to control midline, the entire midline. So it's not just a pelvic floor issue, it is a core issue, a deep front line issue, which means we're going to have foot issues, knee issues, pelvic issues, lumbar spine issues, cervical spine issues, and jaw issues. 9 muscles. Only reason I put this, I'm not going to ask you name the 9 muscles of the pelvic floor. That won't be on the test. Don't worry about that. Only reason I put this on here is because we think of the pelvic floor as just one structure. It's 9 individual muscles on each side. So 18 total muscles that have to all at the same time do their job at the right time in the right sequence. This is why pelvic floor issues are so common and so frequent, because it's 9 muscles. It's a group project with 18 people in the group. If you guys had to do a group project with 18 people in the group, how well do you think that would go? Do you think there'd be a little bit of friction at some point? Do you think there's probably going to be 1, maybe 2, probably with that volume, 3 or 4 people in the group that aren't going to do anything until it's the day that you present and they're going to get all their points? That's the pelvic floor. That's why we have so many pelvic floor issues, because it's not just one muscle that's having to turn on and turn off. It's 18 muscles that are having to work in coordination that go from the sacrum to the ischial tuberosity, from the coccyx to the ischial ramus, from the ischial ramus out to the greater trochanter, from the sacrum to the pubic symphysis. So they run in different places and create this floor, and they all have to do different things. And then they all have to work together to do their different things. So that's why pelvic floor issues are so prevalent. It's not a pelvic floor issue, it's a group project issue. And if one person in the group's not doing his job, the entire pelvic floor is going to be compromised. And again, I think I've shown you guys this one before. The pelvic diaphragm is pretty much a mirror image of the actual diaphragm. The difference, the diaphragm is one muscle. When you get an impulse to contract the diaphragm contracts and draws the lungs down. When that impulse, that action potential is gone, the diaphragm as a whole relaxes and the lungs move back up. The entire diaphragm contracts, the entire diaphragm relaxes from one action potential. Now, the frequency of those action potentials, now it's a bigger inhale, it's more frequent inhales, but the whole diaphragm is doing its job. Pelvic floor is 18 of those. You have to get 18 synchronized action potentials for the diaphragm to do its job versus one. Now, which is more critical? The pelvic floor doing its job or the diaphragm doing its job? The diaphragm. So, less risk of error. One action potential controls the whole diaphragm. You have 18 at the pelvic floor. That's why we see so many pelvic floor issues, not as many diaphragm issues. Now, I say that with the last week. See, all the time we see breathing issues, but the diaphragm is usually, it's not necessarily just a diaphragm issue when we see breathing issues, breathing problems. The two have to be coordinated. So the one action potential of the diaphragm has to then be in coordination and work in coordination with the 18 action potentials of pelvic floor. So as the diaphragm is activated and is drawing the lungs down, the pelvic floor has to respond appropriately. And that's going to, how the pelvic floor responds to that is going to change based off of whether I'm in the standing posture or whether I'm in bottom of deadlift or whether I'm in an asymmetrical stance or a single leg stance. The diaphragm, the job of the diaphragm, standing is always the same. The job of the diaphragm in bottom of deadlift, it's the exact same as it was in standing. The job of the diaphragm in single leg stance, it's the exact same as it was in the other two. Asymmetrical stance, the job of the diaphragm is doing the exact same thing. The diaphragm isn't going to change how it does its job based off of the posture because we're not changing anything. The pelvic floor, on the other hand, each one of those postures is going to change what the sacrum's doing, what the ischial ramus, what the pubic symphysis, what the coccyx is doing, how they're aligned. So the diaphragm's got the easy job. It just turns on and turns off. The pelvic floor has to react and respond to that. And how the lower body is aligned, symmetrical, asymmetrical, single leg, how the hips are aligned, fully extended, slightly flexed, maximally flexed, all of that is going to change what's going on in the pelvis, which is going to change how that group project has to accomplish the project. So that's why when we see pelvic floor issues, they're a lot more complicated because you're constantly trying to hit a moving target. And one of the things that we don't appreciate about the pelvic floor, every time the diaphragm is doing its job and contracting, the pelvic floor is having to react and respond to that. And it has to do so appropriately, which is also why pelvic floor issues are so hard to address, because we try to address pelvic floor issues as static problems. The pelvic floor is constantly adapting and adjusting to the diaphragm. And when we try to address pelvic floor issues, we try to come at it from a static issue. The pelvic floor is always adjusting. It's not just when we're going to the bathroom. If we have a breathing issue, we have to consider the ripple effects into the pelvic floor. Because if the diaphragm is not doing its job, the pelvic floor is also going to change what it's doing. Diaphragm, and this is also where if you run into somebody and they're a chest breather, they start using all of the accessory muscles of respiration to breathe, and they don't know how to activate their diaphragm. That diaphragm has become a little on the inhibited side. What do you think is happening to the pelvic floor? Because if the diaphragm's not constantly turning on and turning off, the pelvic floor is not having to constantly react and respond to that, we decrease the activation of the diaphragm, we're decreasing the activation of the pelvic floor. When it's not turning on as frequently, and when it's turning on, it's not as bright as it should be. So we start to run into pelvic floor issues. Again, that's why addressing breathing and getting the diaphragm to do its job is so critical, not because of what the diaphragm needs to do, but because of the rebound reaction of what that creates in the pelvic floor. Because we have to have the pelvic floor doing its job. And which do you want to teach more in rehab? Kegels or diaphragmatic breathing? Which one's going to be less awkward? Diaphragmatic breathing. So through breathing, we can access what's going on at the pelvic floor. And then by manipulating the posture, we can manipulate what's going on at the pelvic floor. One of the easiest ways to most fully engage the pelvic floor from a rehab standpoint is through the bottom of the squat. Because that puts the most stress, that's stressing the pelvic floor from a postural standpoint to the highest degree because of the positioning of the trunk, because of the positioning of the pelvis, because of the position of the femur. And then we're asking it to breathe and create intra-abdominal pressure. So if you have a pelvic floor issue, at some point, we have to have that person in the bottom of the squat posture and just have them breathe. And surprisingly, just getting somebody in the bottom of the squat posture and having them breathe does a lot for the coordination of the pelvic floor and the diaphragm, just to get them to turn on. To the point that if I'm concerned about the pelvic floor, I'll have that person in the bottom of the squat. I don't care how they get in the bottom of the squat. The only thing I have with that is if we're talking bottom of squat, this is not the bottom of the squat. If I'm sitting on a 6-inch box, that's not the bottom of the squat. That's sitting on an elevated box. My hips can't be in contact with anything. I have to actually, my only point of contact has to be through my feet. So I can't sit on the box and think I'm doing bottom of squat work because I'm taking the pelvic floor offline with this. So if I'm wanting to put somebody in the bottom of the squat to access the pelvic floor and to work on the pelvic floor, I actually have to put them in the bottom of the squat. So that would be one of those times I'm going to elevate their heels. I'll elevate their heels as high as we need to, whatever we need to do to allow them to get down and sit in the bottom of the squat comfortably. And then we'll sit in the bottom of the squat, heels up on a 2x4, heels up on two 2x4s, heels up on a 6-inch angle board, whatever it takes to allow them the ability to get to the bottom of the squat. And then we're going to breathe, and then we're going to do things in that bottom of squat position. But the ischial tuberosities can't be resting on anything. If the ischial tuberosities are resting on anything, it's not bottom of squat, it's a sitting posture. And we're not going to access the pelvic floor the same. So pelvic floor issues, got to address the squat. We've got to get in and work on the squat. Oh, talk about that one. We're going to come back and talk about the jaw a little bit more on the back end of this. But for right now, just like we've been talking, there is a direct connection between the pelvic floor and the jaw. If you have a pelvic floor issue, you'll also likely have a jaw issue or a tie into the jaw. It goes psoas iliacus QL up into the diaphragm, depending on which path you want to take, anterior longitudinal ligament, up through the viscera, up through the transverse thoracic, the sternum, into the scalenes, into the infrahyoid muscles, up through the longus colli, longus capitis, into the infrahyoid muscles, up into the suprahyoid muscles to the pterygoid and the temporalis. So we have that direct tie-in. If you have somebody that's lacking hip extension, excess tension through the psoas, there's going to be some excess tension up here. Listen to the Bobby Bones Show every day. When I say I listen to the Bobby Bones Show every day, that's all that's on in my truck. I listen to the podcast just because I don't like listening to commercials, and I listen to their podcasts, and it just takes me through the day. So anywhere I'm driving, I've got the Bobby Bones Show going on in my truck. And one of those, all the time I'm sitting here thinking, I could probably fix that. One of the things that the host, Bobby Bones, always talks about is he has an issue grinding his teeth. He just grinds his teeth, grinds his teeth, grinds his teeth. He's tried Botox injections, that helps a little bit, but when the Botox starts to wear off, he continues to grind his teeth. He wears mouthpieces, but he continues to grind his teeth. He's done this, he's done that. Nothing helps with his teeth grinding. Wakes him up at night, has to go to the dentist, he's fractured his jaw, all kinds of stuff. Always a jaw issue. And then one of the things I talk about is, one of the things he talks about, he's also super inflexible. He's never been able to touch his toes. He's never been able to do blah, 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 blah. Always has flexibility issues. Do you think there's a connection? Can't touch my toes. Things can't turn on. Things can't turn off appropriately. We're going to carry excess tension. If I'm carrying excess tension through my hip flexors, up through my diaphragm, guess where it ends up? Up in the jaw. Because of the tie into the autonomic nervous system, there's always going to be that low level of threat, fight or flight versus rest and digest. There's always a low level of tone. It's going to push us into a sympathetic hyperarousal state, which means we're going to create a low level of tone because it's a threat. Things are going to continue to turn on. What's that turn on in the jaw? That's the masseter, the pterygoids. Going to have a grinding issue. My dog has had a popping and a clicking in his jaw since July. Finally took him to the vet because I was concerned, worst case scenario, he's got a tooth issue, he's got an abscess, it's decaying, he's going to have to have his jaw removed. Those are the thoughts going through my head. And we take him, they do x-rays, everything's fine. My dog has a TMJ issue. Like, are you freaking kidding me? The only saving grace was it only cost me $35 to figure out it was a TMJ issue and not an abscess or anything like that. So guess what I've been doing with my dog? We've been doing a lot of manual work. Put some needles in around his ears. Yeah, he'll let me do that. He's a very low-level dog. But get in there, work on his pterygoids, work on the doggy version of a masseter, work on all of this stuff. And guess what? It goes away. My dog is also, it's kind of weird. He's a very low-key dog, but he suffers from anxiety. So he's a very high-strung dog. So I'll do some things at his jaw and it'll make it better for a little while. But then as soon as he gets up and, he sees the lights on at the neighbor's house, he's in alert mode and clenching and the popping and everything comes back. So I think the jaw, and why we're going to talk about more of this later, the jaw is an area. When was the last time you guys did anything with the jaw? The only time, from a rehab standpoint, up until recently, the only time I've ever done anything with the jaw is if somebody actually had a TMJ issue. We would get in and we would do some massage, very low level. That's it. But at the same time, the jaw is very intimately tied in with the diaphragm, with the pelvic floor, with hip extension because of the deep front line. Especially if you have that athlete, that individual that you're working with, that is a little bit more of the type A type person where they're bringing a little bit more anxiety to the table. Because as soon as they're bringing a little bit more anxiety to the table, that's fight or flight. There is that direct tie-in between the autonomic nervous system and our deep front line. So we're going to carry a little bit more, we're going to tend to carry a little bit more tension into the structures of the deep front line. Breathing and gait. We talked about kneeling in class yesterday. How do we access the psoas? Easiest place to access the psoas is right up here, L1, T12, lowest rib. And you can see right here in this little crook, you have the psoas tendon that inserts into the vertebral body. You have the QL, which inserts into the transverse process, and you have the diaphragm. Diaphragm and psoas are very intimately tied together in this area. So guess what? If you have a diaphragm issue, you have a diaphragm that doesn't work the way that it's supposed to, that's going to change what the psoas does. If you have a diaphragm that's locked down and it just doesn't want to do anything, it's going to affect the psoas. When we run, The psoas and the diaphragm have to work together to allow us to breathe, to allow us to effectively breathe. So we have to understand, if we have a diaphragm issue, if we have a psoas issue, if we have a hip extension issue, if we have an anterior pelvic tilt because of a psoas, whatever we think is going on, if you have a hip extension issue, you have a diaphragm issue. If you have a diaphragm issue, you have a hip extension issue. So say that a different way, if you have a breathing issue, you have a hip extension issue. That's going to be affected as we add speed to what's going on. It's going to make when we walk, that's going to change things. When we run, it's going to significantly magnify things. This is also why, because of this intimate connection between breathing and gait, if we can address breathing issues with our athletes, we can improve performance. It's not just box breathing. It's not just inhale for a 4 count, hold for a 4 count, exhale for a 4 count, pause for a 4 count. It's not just the box breathing. Box breathing is our entry level into breathing. Actually getting in and working on some performance-based breathing actually train the diaphragm will have a ripple effect down into the hip, especially as we start adding velocity to whatever it is that we're doing. The QL is not as intimately tied in because it stops it attaches to the iliac crest. It's just there. This is an area that we can access all three, the psoas, the quadratus, and the diaphragm. Easiest way to find that, find the transverse processes of the lumbar spine, find the lowest rib, and where that lowest rib and the transverse processes come together, that's right where those three structures meet. If you're using your thumb, getting in this area, you're probably catching a little bit of all of those. You're not going to be able to differentiate necessarily, is this more psoas, more QL, more diaphragm. This is a spot that is typically tender for most people. Surprisingly, if people have a hip extension problem, this area is significantly more tender. Those individuals I've run into that have low breath hold times, this area tends to be a little on the uncomfortable side with them as well. Again, as we look at this now from the psoas, when you look at the anterior side, the psoas actually passes through the crura of the diaphragm. It's that close of a relationship. Some articles, some research that's looked at this actually says some of the fibers of the psoas intermix with the fibers of the diaphragm, the crura of the diaphragm. Some articles say that, some articles don't. If we believe it, wonderful, it adds to this. If we say that's a crock of whatever, we don't believe that that's there, what we can't ignore is the fact that the psoas and the diaphragm are literally living on top of each other. So there's the likelihood of an interaction between the two is very, very high. So we come down to the psoas, and again, psoas sits right on the anterior hip joint. So like if this is my hip joint, this is the actual front side of my hip, my femoral hip, psoas sits right on top of it. It's in direct contact with that. I think there's a little bursa in there, but other than the bursa, the psoas is right on that anterior hip joint. A lot of times people have pinching in the front of their hip. Could it be some bony issues at the rim of the acetabulum, less of the neck of the femur? Yeah, it could be. Or it could be that psoas is getting pinched there. One of the things we run into with post-op hip patients, if they've had bony work, one of the things that they'll complain about is starting about week 8 and it goes to about week 16, the pinch that they had that led to surgery is actually getting worse again. And they're now freaking out because I just had hip surgery to get rid of the pinch and it had been feeling better, but now all of a sudden it's getting worse. Well, at week 8, we now have a really large bony callus that sits wherever they did that bony work. So if they go in and they clean up that acetabulum, which a lot of times they'll clean up the anterior side of the acetabulum because of a cam impingement, if I shave that down, we're going to get a bony callus that is very prominent in that area. And it's really large at week 8. It's the largest it's going to be at week 8, and then the body starts to absorb that. So at week 8, they start to get this pinch. Well, they get this pinch because this smooth surface that the doctor went in and smoothed down now has this giant callus that's sticking out anteriorly into the backside of the psoas. How do you think that's going to feel? Every time that psoas is moving up, it's going to hurt. Every time I flex up, it's going to hurt because I'm impinging the psoas on that bony callus. That's a natural progression of healing because the body is going to slowly start to absorb that, and about week 16, it's usually completely resolved. So week 8 to 16, patients really start to freak out because they think the surgery failed. It's just the bony callus, the natural healing progression. It starts to go away about week 16. Now, we can do some things to address the psoas and take away some tension in the psoas through some breathing, through some stuff in the rest of the deep front line, as well as directly accessing the psoas to help manage the symptoms a little bit, but really it's a natural healing progression. They get to week 8, it starts to go away, or they get to week 16, it starts to resolve itself because the body is starting to absorb that callus. I want to read out of this Anatomy Train's Visual Assessment and Anatomy Train's book, because they talk about this for just a second, if I can find it, because I don't think this is something that we appreciate very well. Psoas and diaphragm are part of one entity. Blah, 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 blah. The psoas roots the diaphragm to the legs. Where these two muscles meet is where walking and breathing meet. And again, I'm going to continue to harp on breathing. This is about the millionth time. For those of you guys that have been with me last year and this year that I've talked about breathing, for you guys, about the 100,000th time we've talked about breathing. We talk about gait training. In our world as athletic trainers, from a rehab standpoint, we all learn gait training. If you can't breathe, your gait training is not going to matter. So one more time, if we haven't addressed breathing, and if we haven't made sure that the mechanics of ventilation are correct for the task at hand, and we go to do gait training, the diaphragm's not doing what the diaphragm's supposed to do. The psoas can't do what the psoas is going to do. You're going to run into an identity crisis, and we're going to have all these problems. And as athletic trainers, as a profession, we love to jump straight into the fun stuff, the stuff that looks functional, the stuff that looks sport specific. Let's get people off the table and let's actually get people up on their feet and let's do things. And I'm not opposed to any of that stuff if we have checked the boxes on all the things that need to precede that. And if we haven't addressed breathing, if we haven't got somebody to where they can actually engage their diaphragm and breathe in and out through their nose without any chest movement, if we haven't done that and we stand somebody up and we do gait training drills, just send them home, because we're wasting our time and we're wasting their time. Because if we haven't addressed the diaphragm, the psoas, again, isn't going to do what the psoas is supposed to do. And if the psoas and the diaphragm aren't doing what they're supposed to do, anything we do in the world of gait is going to be thrown off. Our timing is going to be off. Everything's going to be thrown off. We also love to stretch out the hip flexors, psoas, iliacus. We love to stretch those out. One more time, if we haven't addressed the diaphragm, if we haven't addressed the breathing, we can't expect any success in creating any kind of tissue elongation for whatever reason within the psoas. So again, if we're going to have any conversation about doing anything that involves the psoas, gait training, stretching out the psoas, working on any kind of anterior pelvic tilt, working on tight hamstrings, any of that stuff, if we haven't made sure that breathing that box is checked off, we will not be successful with this. And one more time, if we think about those areas, specifically gait training, stretching the hip flexors, working on tight hamstrings, how often are we dealing with those situations and it gets frustrating because it just keeps going and going and going and going because we're not seeing the improvements that we want to see? And again, I'll throw out there, if we're not seeing the improvements that we want to see, something is wrong. Either we're doing the wrong things or we're just not approaching it correctly. And I venture to say we're just not approaching it correctly, because there's a lot of great drills that we do, but one more time, if we haven't addressed the diaphragm first, we can't address the psoas. If somebody can't breathe through their nose, if somebody can't ventilate without having to open their mouth, without having to use their rib cage to draw air in, if they can't engage their diaphragm and maintain diaphragmatic breathing, we can't expect the psoas to do what the psoas is going to do. Because as soon as we introduce any level of stress to the system, any level of challenge to the system, we're going to default back to our highest level of training, which then shuts off the diaphragm, changes what the psoas is doing. So now, if you go to your clinical sites this afternoon and you're working with an athlete and you're like, oh, I'm going to stretch out this person's hip flexors, and Brandon this morning said something about we need to make sure they breathe, and you lay them down and you watch them and they're breathing diaphragmatically, box is checked. Let's go right into the couch stretch, great stretch. Or any of our hip flexor stretches, great stretch. I did exactly what Brandon said. Check the box, they can breathe, let's move on to the stretch. Wonderful, that's the first box. Now, while we're doing that couch stretch, or while we're doing that inline half kneeling hip flexor stretch, what I want you to pay attention to is no longer the pelvis. I really could care less what's going on here. What I want you to pay attention to is what's going on with their belly, what's going on with their mouth. Because if they could breathe on the table and you check that box and they were breathing diaphragmatically, you did exactly what I told you to do. And now you go to the next drill, which is now appropriate for them, and you're going to do that half kneeling hip flexor stretch. Remember, that half kneeling hip flexor stretch is now a stress you've introduced to the system. They're going to default back to what they're used to, which isn't what they just did on the table. They're going to go right back to using their chest, opening their mouth to breathe. That's what you have to stop. Stop them from breathing. Just put your hand over their mouth, nose, they'll pass out, they'll default. No, not like that. Have them re-engage what you just had them do on the table. Have them close their mouth, breathe in and out diaphragmatically through their nose. And what you'll find is as soon as we default to that, now what we need to do is we get them down into that half kneeling hip flexor stretch. And I could care less what we spend too much time paying attention to the wrong details. And we argue about the wrong details. You know, we got to keep the shoulders back. You've got to engage the glutes. None of that matters if their mouth is open and they're breathing through their chest. We're arguing over the wrong details. So I don't care. You can pick the worst version of this and you can do it all wrong. You can do, you know, you get, if you were posted up on social media, you get torn apart because everybody pick all the things that you did wrong. If you just have them shut their mouth and breathe diaphragmatically while they're here, that breathing is going to promote that stretch. Then, if they've done that, then we can discuss, well, should they be pushing down here? Should they be holding something? Should their shoulders be back? Should they let their chest come forward? Should they engage their glutes? Only have those conversations after you shut their mouth and have them breathing in and out through their nose and engaging that diaphragm. If you've done that, you can fight over whatever the details are. They'll work. The nice thing is, pick whichever version of that, the good, the bad, everything in between. If they're breathing through their nose, you've already taken a step forward in actually getting that psoas to do what it needs to do. And that's what we typically miss. We're arguing and discussing the wrong details when there's no way we can actually get that psoas to do what it needs to do because the diaphragm isn't doing what it's supposed to do. And because they are so intimately tied together, if one's not doing his job, the other's not going to be able to do his job either. All right, so now, the unique thing about the deep front line, this does present something that none of the other lines do. And that's its direct tie into the autonomic nervous system. Remember back earlier in the semester, we talked about the autonomic nervous system, fight or flight, rest and digest. The deep front line, the tone of the deep front line and what's going on the deep front line is a direct reflection of the tone and what's going on within the autonomic nervous system. But at the same time, what's going on in the deep front line sets the tone for what's going on in the autonomic nervous system. So there's a very symbiotic relationship between the deep front line and the autonomic nervous system. When we look at the vagus nerve and all the different plexuses that it has, the esophageal plexus, the cervical plexus, the splenic plexus, the hepatic plexus, the celiac, the mesenteric, the sacral, the pelvic. I think that's all of them. All of these plexuses, a plexus is just a collection of nerves. All of these plexuses are intertwined throughout the viscera. which again, because of the deep front line and how the deep front line runs through there, is going to be very heavily influenced by the sensory input that is provided to the vagus nerve. And that's going to set the tone or influence what's going on within the autonomic nervous system from a fight or flight or rest or digest situation. It's one of the reasons why one of the most uncomfortable things for us is, how awful would this be for class? Before class, you can start training for this next semester. Before class, next semester, before you walk in the door, you have to drink a full bottle of water. I don't care what size. And then you have to be able to buy the bottle of water, not a little shooter of water, but a full bottle of water. So you have to drink a full bottle of water before you come into class. Then while you're in class, every 5 minutes, we have to take a drink of water. What's going to happen what's going to happen about 30 minutes into class? Somebody's going to have to go to the bathroom. As the bladder fills up, that is one of the that gets the attention of our nervous system very, very quickly. It becomes very uncomfortable. It wakes us up while we're asleep. Not many other bodily functions wake us up while we're asleep. Now everybody's taking out and drinking their water, right? So why? As the bladder fills up, pelvic plexus, sacral plexus, we're creating input through the vagus nerve to the central nervous system that affects autonomic tone. That's a stress to the body. It wakes us up, you go to the bathroom. As your bladder fills, your level of focus changes. You become more focused on what's going on, less panoramic, because that's a stress to the body. You have to go to the bathroom. It's hard to focus on anything else the more you have to go to the bathroom. If you've ever eaten at Taco Bell and then gotten into a car, very stressful situation. Especially if the exit's closed or the gas station's closed and you have to get to the next one. You find things out really quick. Why? The reason that those are so stressful situations, again, is because what's going on physiologically and the direct tie-in that has to our autonomic nervous system. And it sets the tone of our autonomic nervous system. Because it sets the tone of our autonomic nervous system, it also influences what's going on in the deep front line. This is also why, if you have somebody where we're dealing with sympathetic hyperarousal or high levels of anxiety, addressing the deep front line can actually pull that down just a little bit. That's one of the reasons why we talk about, again, diaphragmatic breathing and what that does. Engaging that diaphragm is going to pull down the tone of that autonomic response. It's going to take us out of a fight or flight response into the rest or digest response. Addressing the psoas, addressing the hip flexors, we can start to change the tone of what's going on with the autonomic nervous system. Much more so than isolating and stretching out the hamstrings or the glutes or the piriformis. We're not going to change the tone of what's going on. So we have to keep in mind that when we run into these situations, we can then leverage the deep front line to have an effect on the the autonomic nervous system. One of the things, if patient comes in, post-op patient, they tell me they're having trouble sleeping. I can't fall asleep. One of the things I have all of them do, and this isn't just my post-op patients, this is anybody that tells me they're having trouble sleeping. You're going to go to bed at 10 o'clock. At 9:30, I want you to get down on the ground and you're going to roll around on a foam roll. And I want you to foam roll your midsection. You're going to foam roll your rectus, you're going to foam roll your obliques, you're going to foam roll your hip flexors. Not necessarily because I want to change what's going on in those tissues, but I want the deep pressure into all of these plexuses. Deep sustained pressure is a very calming and relaxing type of a sensory input, which can then pull things down just a little bit. After they do that, I'm going to have them get into some kind of hip flexor stretch. I don't care, I typically show them the couch stretch, it's just the easiest one. Again, because I'm trying to pull down the tone of that autonomic nervous system. And the whole time they're doing this, mouth's closed, I want you focusing on your breathing, inhaling in and out through your nose. So we can directly go after the deep front line to change the tone of that nervous system. We see somebody with an anxiety issue, we have to understand and we have to consider that there's also we're going to see reflections of that within the deep front line. Now, with the vagus nerve, we can secondarily address it through deep pressure to the abdomen by engaging all those different plexuses. But we also have direct access to the vagus nerve at the ear. So if somebody really has anxiety issues, I actually will spend some time working on their ear. Somebody's in a high level of fight or flight, especially post-op patients, we'll come in and I'll address the ear. Somebody has trouble sleeping, we'll come in, I'll address the ear. Individuals that have migraines, you see they have that daith piercing, I think that's how you pronounce it. One of the reasons why that has such an effect on those people suffering from migraines has nothing to do with getting that little piece of the ear pierced. It has to do with the reason that it has an impact is that part of the ear is innervated by the vagus nerve. So you have that piece of metal in there, and that addresses, it's like needling into the inner ear, or needling into the outer ear. So we see it have an effect on migraines, different things like that. Bad Boys, you guys seen that movie? The woo-saw part, everybody likes to, there's a meme on your phones, Martin Lawrence getting in there, woo-saw, he's all stressed out. The reason that he's rubbing right here isn't because it's just funny in the movie, but because direct pressure here is going to engage that vagus nerve. Sustained direct pressure, again, is very calming. So it's a way that we can pull things down just a little bit. How do we address this? You can do it manually with your hands. Graston tools can get in, it's very tender. Surprisingly, the most comfortable way for the patient is actually dry needling through there. You would think it would hurt, but it's not very bad. It has pretty good outcomes with that. So we can engage all of these plexuses lots of different ways to where now we can address a fascial line and have an impact on the tone of the autonomic nervous system. On lower leg, the deep posterior compartment is where we see the deep front line occupied. The posterior tibialis, the flexor hallucis longus, flexor digitorum longus. It's the deepest compartment. From our world, that's where we're concerned about compartment syndromes. The reason we're concerned about compartment syndromes, the vascular, the venous, the arterial, and the nervous bundle all sits kind of right in between those three and just in front of the soleus. It's a hard area to access, but we actually can get in there. And when we actually go to the lab next week, early next semester, I'll show you guys how we can actually manually access the posterior tibialis, bypass the soleus, and not have to try and fight our way through the soleus, through the gastroc, to where we can actually have an impact, a much better impact on what's going on. It's a very easy way to do it, and we can find ways for our patients to do it on their own so they don't need us as well. The anterior hip, the femoral triangle. This is an area that, again, in our formal education, we learn about this, but in all reality, when have you guys ever had to take this area into consideration with anything that you've done? When have you ever had to consider the artery, the vein, the nerve that passes through that femoral triangle? Ever? With anything? Not necessarily. You ever had any patients that complain of neurological symptoms in the front of their leg? Tingly, burning type sensations, upper quad? Femoral nerve impingement in the anterior hip. It's cutaneous distribution right there. You'll see that burny, tingly type sensation here. How do we address that? Well, the more common, the initial go-to is either some type of hip flexor stretch, some type of prone quad stretch, or trying to get in here manually. Well, if we get in here manually, there's not a whole lot of space in here. So if we're getting the numbness, the tingly, the burning type sensations, and we're compressing this, odds are we're going to get into that nerve and continue to make the problem worse, or at least aggravate it or irritate it, not necessarily in a manner that's going to be progressive. The pectineus. You guys remember learning about the pectineus in any of your anatomy classes? Probably you heard the pectineus, but that was about the extent of it. The pectineus is a muscle that goes here, and then it kind of gets glossed over for all the other adductors. Pectineus has a very broad attachment point into the ischial ramus, just lateral to the pubis. It sits right behind the artery, the vein. This can be a very impactful area for us to target manually. If somebody's having any kind of adductor issues or any kind of medial knee pain, we can take a look at that to see if there's any involvement there. Oftentimes we forget about this, the little pectineus, and we jump straight to it's an adductor problem and go to stretching the adductors. And it just continues to perpetuate its issues. So we can actually get in here and address the pectineus. One of my favorite areas to needle, well, not favorite areas, that sounds weird. One of the areas, if somebody has any kind of involvement of the psoas, one of the areas I have the most benefit and get the most benefit out of needling is in the psoas. And take the needle, you find the belly button, go about 3 inches lateral, take a really long needle, and you thread it through there, try to miss all the stuff and hit the psoas. No, we go right into the front of the hip. And if you find the ASIS, so if you find the inferior part of your ASIS, you go down about 1 inch and go medial 1 inch, and you're going to be right over the actual hip joint. And we can kind of get in there, and we're going to be just lateral to that femoral nerve as it comes through there. We're going to catch that right on the lateral border, the medial border of the sartorius. And you can check yourself, the medial border of the sartorius, and we can kind of get in there and address that. If you don't want to needle somebody there, you can actually do any kind of manual technique into that area as well. You just want to find the ASIS, go down 1 inch, go medial 1 inch, find where that psoas is, make sure you're just medial to that psoas. If you're just medial to the psoas, you're going to be right over the hip joint. You're going to be a little too lateral to catch that nerve, and you're going to be right over that psoas tendon. We can get a lot of good input to the psoas tendon. We can create some positive change to the psoas tendon if we address that area. Pectineus, we can get in there and address that as well. We do have the artery and the vein that's right there. This is where some of the BFR stuff comes into play. When I say the BFR stuff, I don't actually mean utilizing the BFR, but a lot of the BFR, depending on which brand you have, they come with, the pulse Doppler, couldn't think of the name of it, where you try to find, where you can put it on and you can actually hear blood flow. So that's something you can actually find where the artery and the venous bundle are, mark that, and then if you go just medial to that, you can catch the edge of the pectineus, either again manually, or you can needle that area, different things like that. And again, if you're having any kind of adductor type issues, any type of medial knee issues, if you're having some IT band issues, this is an area that we can investigate for any kind of involvement. And again, and another benefit is if we catch it right where it inserts into that ischial ramus, then remember, where a muscle, the tendinous junction where it interacts with the periosteum is very rich from a neurological standpoint, so we can create a lot of good input directly into that area. Posterior knee, popliteus has become quite popular. Let's go in and let's address the popliteus. And I'll be honest, most people when they address the popliteus incorrectly. This is an area that's going to be uncomfortable no matter how we do it, because that's just a tender area to begin with. But you also have venous and arterial and a nerve bundle that sits right in the middle of the back of the knee. So just putting pressure on that is going to be uncomfortable for a lot of different reasons. Popliteus runs from, the easiest place to access the popliteus is the superior medial tibial plateau, posterior side. Most people go directly into the crook of the knee, the middle of the knee crease. You're catching joint capsule, you're not getting popliteus. It's going to be tender, and a lot of people think, oh, that's tender, I'm on the right spot, I found a trigger point. No, it's just a tender spot to begin with. We actually need to come down significantly further. We're below the knee joint, posterior superior portion of the tibia, and you're going to access the popliteus, especially if you can get just medial to just inside of the medial gastroc head. Again, this is an area from a needling standpoint, from a manual standpoint, you can have lots of good benefits from if you can get into that popliteus, because oftentimes that popliteus is going to carry a lot of extra tension. Which then, if you remember what the popliteus does, it doesn't do anything other than lock and unlock the knee, the screw home mechanism. So if somebody's having trouble with end range knee extension, they're lacking end range knee extension, there's likely going to be something going on in the popliteus, and we're going to have to address that some way, shape, or form. Once again, it comes in handy if you have a BFR kit and you can figure out exactly where that venous bundle is so you don't hit it, and then just go medial or just lateral to that, and you can catch that. Popliteus goes from medial tibial plateau up to the lateral condyle of the femur, so it kind of runs up and at an angle. The medial portion is much broader, so it's much easier to hit that manually or with a needle than the lateral side. And again, you can do either one. Right? But oftentimes, when we do that manually, we're going way too high, and we're actually in the capsule of the knee, not actually in the popliteus. Both are going to be tender, one's just not going to be beneficial. Popliteus is the homecoming queen when it comes to posterior knee pain. We address it. We try to address it. If the posterior knee pain doesn't go away, we have to consider: are we in the right area? Are we hitting the popliteus? If you lowered where you're doing your manual pressure actually down to that posterior tibia, and now you're in the right place, and that posterior knee pain is just not going away, it might not be the popliteus. This is one of the most overlooked areas that we run into. We always blame the popliteus, and we don't consider the other things that refer pain here. The posterior cutaneous branch of the obturator nerve. Remember, the obturator pelvic floor muscle sits all the way up here. Exits through the obturator internus, runs down the posterior portion of the knee, actually goes into and through the posterior joint capsule, into and innervates the actual joint itself. Well, if there's impingement up here in the pelvic floor, or if there's impingement anywhere through that posterior adductor pathway that it takes, it can refer pain anywhere along the hamstrings into the posterior aspect of the knee. And we oftentimes overlook this. If somebody has posterior knee pain, posterior hamstring pain, they can't engage their diaphragm. We know their diaphragm's not working. What does that tell us is happening to their pelvic floor? It's not working either. That person has posterior knee pain. We've addressed the popliteus. It's not working. Just like in CPR, if it's not working, trying to get air in, it's not working, we re-tilt the head and try again. We address the popliteus, it's not working. We reassess, we go a little bit more inferior, a little bit more medial, catch the popliteus in the tibia. That's still not working. We made sure, we double checked, we made sure we're addressing it in the right place. It's still not working. We need to consider something else. And that something else can be the posterior branch of the obturator nerve. And we have to address the pelvic floor in that instance, or we have to address any hang-ups in this nerve. This one oftentimes gets overlooked because we jump straight to hamstring or popliteus, one or the other. Because if you look at where its pain referral distribution area is, it's all hamstring, posterior knee. So one more time, if again we're not getting the outcomes that we want, we need to consider some other things. This is often one that we don't even pay attention to. The jaw, talked about how the jaw, we use the jaw a lot. Eating, drinking, talking, how we express ourselves. We use the jaw quite a bit. The jaw is directly tied into the deep front line. We have our suprahyoid muscles, we have our infrahyoid muscles. Basically, they're just named by where they are in relation to the hyoid. Those below are infras, those above are the supras. It's not uncommon. It's not uncommon if somebody has a problem with their diaphragm, a problem with the pelvic floor, they're also going to have a problem with their jaw. TMJ is a deep frontline issue. Jaw pain is a deep frontline issue. If somebody, and yes, indirectly because of the fascial connections, but if somebody can't breathe through their nose, what do they have to breathe out of? We're not turtles, we can't breathe out of our butts. Turtles actually can't breathe out of their butts, according to the Bobby Bones show. I haven't fact checked them, so I might be wrong. But if we don't breathe through our nose, our only option is to breathe through the mouth. If we breathe through the mouth, where does the mouth have to be? It has to be open. If we spend enough time breathing through our mouth, what happens? At an early age, it literally reshapes the jaw. It reshapes the face. As soon as we start talking about reshaping the jaw and the face, that's going to change how the muscles do their job. If we're carrying any kind of excess tension, or if we have any kind of imbalances here, that's going to have a direct fascial connection into the rest of that deep front line. So one more time, we're talking about breathing. If somebody breathes through their mouth, we can actually, it's not just engaging the diaphragm and getting the diaphragm to do what it needs to do. It's going to have a direct effect on the jaw. Somebody has tension headaches. If somebody, at the end of their day, they start to suffer from headaches and they breathe through their mouth all day long, we need to address this. Somebody has neck pain, neck issues, we need to look at this. Somebody has neck pain, neck issues, and we watch them breathe and they breathe through their mouth, we have to take that off the table right off the bat. We have two very strong muscles from a force standpoint, the masseter and the temporalis that close the jaw. All the other muscles, those are, when we look at the fiber types, when we look at the orientation, when we look at the shape of the muscles, those muscles are designed completely for forcing closing the jaw. All of the other muscles, when you look at the size of them, when you look at their shape, their fiber orientation, again, those are now muscles that work off of timing. And if you think about language, if you think about how we move our jaw from a talking standpoint, it's a lot of fine motor control. We're not getting fine motor control from the masseter and the temporalis. Those are our steak-eating muscles. We need these to be very big, very strong muscles that generate a lot of force. All the other ones, and if we're constantly keeping our mouth open, that's going to change what's going on in those muscles, and it's going to impede their ability to exert the amount of force that we need to exert. So we can create lots of lasting changes in the jaw by keeping the mouth open all the time and breathing through our mouth, which is one more reason why we need to get away from that. The pterygoids, I went to a whole workshop on the pterygoids. If I had known what the pterygoids were when I signed up for this workshop, I wouldn't have gone to this workshop because it was a very awkward workshop. Imagine showing up in a room of 30 people. You sit at a table just like this. You don't know the person sitting next to you. I'm leading the course. I don't want to take time for people to find partners that they like. So person at your table is your partner. If there's not a person at your table, the closest person to you is your partner. Every table has a box of gloves. We're now going to learn how to palpate the pterygoids. You know how to palpate the pterygoids? You take your finger and you put it all the way back here on the outside of your top row of teeth and you push out. My finger was relatively clean. I'm not too worried about it. But now, go to your partner, and you're going to put your finger inside your partner's mouth. Yeah, how awkward is that? That's a great how would that be if that were the icebreaker for your first year in any kind of program? Your first day on the new job, hey, we got a new person, partner up, we're going to palpate the inside of their mouth. Awkward, but it does, again, if somebody has jaw issues, somebody has neck issues, the pterygoid, if we look at the pterygoid is a reflection of the masseter. somebody has their jaw open all the time, it's going to create a change in that pterygoid. There's going to be some tension in that muscle. We need to take that off the table. You can access it this way, or we can actually access it from a needling standpoint. The only way to make you can, depending on the person, with the Graston tool you can access it, but other than taking your finger through the mouth, a needle or a Graston tool, you really don't have a good option of accessing the pterygoids other than through the mouth with your hand. But again, if you see a mouth breather, that's something we need to consider. Somebody has issues, TMJ issues, this could be a very powerful area, a very impactful area to address. So if we think about it, we're aware of the diaphragm. We talked about the pelvic diaphragm. But really, if we think about it, the jaw becomes our third diaphragm of the deep front lines. If we take out all the muscles, there's nothing there. If we take out the diaphragm, the actual diaphragm itself, there's nothing there. If we take out the pelvic floor, there's nothing there. So the muscular floor of the jaw, the muscular floor, the muscular ceiling of the diaphragm, the muscular floor of the pelvis, all three have to work together to create appropriate pressures and to create support in these areas. If they can't, we're going to have problems. The jaw is an extremely overlooked area when it comes to the deep front line. We address the diaphragm, we address the hip flexors, we know how important the pelvic floor is. There's entire classes and entire certifications to the pelvic floor. We don't give the jaw the value that it should have.